Today, we will be discussing a rare but highly challenging disease, atypical hemolytic uremic syndrome. Our understanding and management of atypical aHUS have significantly advanced over the past decade. Atypical aHUS is now recognized as a prototypical disease caused by dysregulation of the alternative complement pathway, specifically the C3 convertase. Prospective non-randomized studies and retrospective series have demonstrated the efficacy of C5 blockade in treating this severe condition, establishing it as the cornerstone of atypical aHUS therapy. However, this therapeutic breakthrough has been tempered by ongoing challenges in definitely diagnosing atypical aHUS, which remains a diagnosis of exclusion. Despite these difficulties, long-term management of atypical aHUS is becoming more personalized, and lifelong C5 blockade is no longer a one-size-fits-all approach for all patients. Additionally, the development of novel agents targeting the complement pathway shows promise and evolving as a potential therapeutic option. In light of these advances, it's my pleasure to introduce our esteemed speaker, Dr. Christoph Licht, an internationally renowned expert in complement-mediated diseases and the leader in the field of atypical aHUS research and clinical care. Again, Dr. Licht, thank you for coming.
Thank you very much for this kind introduction, and thank you for the invitation to presenting to you this morning. It's a real pleasure.
So I will start with our clinical case. This is a 45-year-old female patient presents with a 5-day history of fatigue, dark urine, and generalized weakness, accompanied by a blood pressure of 160/95. She reports mild abdominal pain and nausea, but denies diarrhea or recent infections. Her family history is notable for a sister who had HELLP syndrome during pregnancy. Initial labs reveals hemoglobin of 8.2, platelet of 75,000, elevated LDH 1200, undetectable haptoglobin, and elevated total bilirubin of 2.8 with indirect bilirubin predominating. Schistocytes are present on peripheral smear. Renal function is impaired with serum creatinine of 4.8 and BUN of 68. Urine analysis shows hematuria and 3+ proteinuria. Complement studies reveal low C3 and normal C4 with a normal ADAMTS13 activity. So the first question that I have, how do you approach to MAHA patient, and what is your initial approach to atypical aHUS patient?
Thank you very much for presenting the case. And I just want to start with a very brief disclosure. I'm a pediatric nephrologist, so I will try to distill from your case and present to you generic concepts, and will be less specific in terms of adult context, if you want, but I think we will have enough opportunity to go into relevant detail there. So from the case that we're dealing with here, the lead laboratory findings are basically the picture of the typical triad of anemia, thrombocytopenia, and impaired kidney function. Hemolysis markers, including cystocytes, as presented. And in addition to that, a family history of a patient with HELLP syndrome or possibly a TMA in context of a pregnancy. So with that, we have already, being aware of the literature, a hint that this could be a patient falling into the box of a complement-driven disease. But let's start with the beginning. The question is, let me see if I can operate. How can I advance the slides, please? Okay. The question at stake here is how to approach a patient presenting like that. And if you take a look at the literature, this is a paper that I found became aware of more recently, which is interestingly just reviewing it from Finland. from a prestigious group looking into the practice of physicians establishing the diagnosis. And as you can see, TMA diagnosis, this is a sample, the total was about 250 patients. The diagnosis of TMA is established in about half of the patients in 1 to 2 days. And roughly in the same portion of patients, treatment is initiated during that same time window. But there is an increasing portion of patients in whom treatment decisions are taken later, as in only after a week or even longer. The bottom portion of the slide shows what physicians were considering in terms of lead clinical features. We just spoke about the MAHA pictures, but they also looked immediately at extrarenal manifestations. So we had to have a patient with impaired kidney function, but be aware of other systemic disease and the possibility that CNS, the lungs, the GI tract, and the cardiovascular system can be involved as well. And you also see here that colleagues considered a whole set of underlying conditions, and we'll come to that group of diagnosis that we can refer to as secondary TMA in a moment. Next slide, please.
You should be able to move it, Chris.
I'm trying it's not moving.
Okay, I'll move it for you then.
The problem is that it's animated, so maybe I just let me try. I have one more. Oh yeah, okay, now and it works. Your question was how to establish the diagnosis, and as you heard from Taha already, it remains establishing a diagnosis of primary complement-driven TMA remains till today a diagnosis by exclusion. And this paper is one of many, but I think this is one of the better ones that really nicely summarizes your thought process and also the steps of action that you should take or consider taking to establish a diagnosis. Top to bottom, it begins with the diagnostic steps of establishing MAHA. We just spoke about that. And then with that, you are dealing with a patient with TMA, and you start excluding your top differential diagnosis. The first one being especially important for pediatricians to exclude an infection, an E. coli-driven, in the past we called it typical or diarrhea-associated STEC aHUS. And as hematologists, you're well familiar with that TTP by looking into ADAMTS13 activity levels. If you're certain that you're not dealing with an E. coli-driven STEC aHUS patient or a TTP patient, then you are left with this list of secondaries that we were just looking at, and that can be patients like your at least a family case, pregnancy-related phenomenon, drug-induced, infection-reduced, associated to underlying autoimmune diseases, and so on. So a secondary TMA, and we'll have to talk about that in a moment in a bit more detail. When you're done with considering those, then you're basically left by exclusion with the primary complement-driven TMA, and that is the patients who in the first place would benefit from complement targeting treatments. Now, let's go to this long list of the secondaries for a moment. And that is important. That's an important take-home point from my point of view. What you see here is basically the same message as on the previous slide again. In the middle, you have the complement cascade. And you have in the yellow box what I keep referring to as the primary complement-driven TMA. So that is where we have some specific defect in the complement system that we can identify, and we'll talk about it in a moment, that lead to this insult to the endothelium and the subsequent cascade of clot formation and organ dysfunction. The purple is the secondaries, and this editorial here says that there is typically no complement genetic abnormality or antibodies involved. So you don't find any generic drivers, no generic defect in the complement system, but you have all these associated kind of, you have the context of, the components that I've listed now twice for you already. But the point to be made is that as soon as you have this initiating insult to an endothelium, the complement provides an amplifying mechanism to temporarily provide a second hit. And that is your chance to use complement targeting treatments, even in secondaries. And again, we'll have to talk about it. So take home primaries with a generic defect in the complement regulatory system versus secondaries where you don't have those genetic or autoimmune forms, but you have complement as an amplifying mechanism. And that leads to, if I could only advance. Yeah, that leads to something that you will hopefully very soon find in the literature. This is an IPNA triggered clinical practice recommendation, call it a guideline paper for the management of atypical aHUS. And that basically puts the components of what I've just told you together. I won't go through it for time again, but it really puts I can share that slide with you. It's the tree of rule out Shiga toxin aHUS, rule out TTP, and be left with the non-TTP, non-Shiga toxin ones, and then consider the secondary cases. And only when you're done with the secondaries, you're in the box of the primaries where complement targeting treatment is relevant. There's two additional points in this slide that I want to highlight. One is pneumococcal aHUS might not be as relevant for you, but for pediatricians it is, which is a specific infectious cause that through neuraminidase and injury to the glycocalyx results in a complement dysregulation on endothelial cells. So that is a standalone diagnosis. You could put it into a box of infection here in the secondaries, but we felt it was important to keep that standalone. And the second group that I want to highlight are genetic causes of TMA that look like primary complement-driven TMA, have a genetic cause but have nothing to do with complement. And DGKE is just one of those examples, but there's others, TSEN, INF2, you might have heard of those, very rare, and they come with other conditions, but the point to be made is look like TMA, look like atypical aHUS, but have nothing to do with complement, even though they have a genetic cause.
Yeah, so I think this is very interesting because going over the diagnostic tree for exclusion of other causes for TMAs and making the aHUS diagnosis, atypical aHUS diagnosis, because I think the complement cascade is the center of this disease. Also, the treatment landscape is always based on the complement cascade. So can you go over the complement cascade, please?
Happy to do that. So we referred to complement a few times now already. I won't torture you with much detail. This cartoon really highlights the key steps. It's an activation cascade, so it is directed from a starting point to an end product, the membrane attack complex, as a product of the terminal pathway. The starting points are the classical, the lectin, or the alternative pathways induction. The classical and the lectin pathways start when you have immune complexes, classical pathway, or you have bacteria with certain carbohydrate repeats at the surface of the bacterial envelope. That's a lectin pathway. Or you have this constitutively active alternative pathway. All three of them merge in this C3 activation step, and out of that comes the activation of C5 activation and the terminal pathway induction. And maybe just for big picture orientation, this activation cascade, as I introduced to you, is obviously tightly regulated with soluble and membrane-anchored regulators. Factor H is the key and probably best known soluble complement regulator, and MCP, membrane cofactor protein, or CD46, is one of the surface-bound proteins that regulates complement. If you have more specific questions, happy to go through those. But the key point now is that this balance of activation and inactivation is specifically dysregulated towards the terminal pathway, especially on surfaces, leading to the clinical picture of atypical aHUS or TMA, or is dysregulated at the level of the C3 activation and leads at that stage to the phenotype of C3 glomerulopathy. So another kidney disease, but very different from atypical aHUS. One is an endothelial disease, the other one is a glomerular filter inflammatory condition.
Okay. So I think we went over the primary and secondary atypical aHUS causes. So how common is anti-factor H autoantibody mediated atypical aHUS can occur? And when do you consider atypical aHUS genetic workup?
Right. So in the flow of this presentation, we're basically now, we have established that the patient has a TMA. We have established the suspicion after going through the differentials, rule out STEG-aHUS, rule out TTP, rule out secondary TMAs. We have established the suspicion that this could be primary complement-driven TMA. And I said that's the ones where you find have a chance to find antibodies and or mutations. Mind you, only in about 60% of patients, you will be successful. There's another 40% where you still have the clinical diagnosis of a primary atypical aHUS, but you still don't find one of those mutations or antibodies. Now, this table summarizes basically both aspects, the genetic and the autoimmune aspects that can lead to dysregulation of the cascade towards overactivation of this terminal component, resulting in endothelial damage. And in red, I'm boxing the genetic causes. So this is now, if you follow the logic of what I've presented, a loss of function set of mutations affecting those regulators. Factor H, as I mentioned, is one of those. It's the most prominent. 20 to 25% of patients are affected by those. Or factor I is another soluble regulator, up to 16%, 15, 16%, and MCP, CD46, membrane-anchored protein, up to 22%, 23%. And then you have genetic defects that can affect complement drivers. So dysregulation can occur either by defect in the regulators or a gain of function type of situation, mutations that enhance the function of propellers of the cascade, and that affects factor B and C3. And you see that they are much rarer, only up to 4% or up to just about 10% for C3 and less for factor B. And then you have, and that was your question, also these antibodies, which often occur but don't have to be affiliated with defects, genetic defects of a group of proteins that we won't talk about in much detail here, the factor H related proteins, but those antibodies are functionally basically resulting in the same problem as a factor H mutation. It's lack of complement protection of endothelial cells, and that can occur either through a mutation or an antibody. And these antibodies, first described in 2005, 2006, at that time it was somewhere between 5 and 10%. That's how it was presented. And the literature, if you look at the European and the US, like North American literature, it's sitting somewhere between that 5 and 6% up to maybe 20%, in Europe a little more. But there is one country that stands out, it's India, for reasons that we can't really explain. They have an incidence of up to 50% of factor H antibodies, and we don't really understand or can explain why that is. But that leads to the fact that, or to the consequence that most of the literature based on larger cohorts with respect to the management of factor H antibodies comes from India. And I skip for time the bottom two since they are not so relevant in this case. If I can just add here, if you allow, out of what I just showed you, now we're in the box of atypical HES primary complement-driven TMA, where those mutations and antibodies are possibly relevant. What is now meaningful diagnostic workup? And this paper is actually one of the better ones. It's an excellent one that I recommend for your reading. That basically says, now what is suggested in the workup of a patient with, the suspicion of a primary atypical HUS, and they basically tell you three things. One is measure, the factors that tell you that the complement system is activated. So C3, C4, CH50. And maybe also the level of some of those key complement regulators, factor H, factor I, and CD46. Remember, that was a surface protein, so you can only do FACS analysis for that for surface expression, and measure antibodies. So this is recommended for primaries. In step 2, you may or you may not, or in addition, you may or may not measure C5b9 in plasma, so the end product of this activation cascade, which, if our concept is applicable, would be elevated. And thirdly, consider genetic workup for, the proteins that or the genes that I just showed you. I would remove from this list THBD, CD41, 141, and DGKE, since again, DGKE represents a non-complement mediated condition, and THBD has been questioned in more recent literature to being really relevant. And happy to discuss the DGKE portion a bit more in a moment. But do genetic testing on all the others. So this is basically what's recommended for the primary atypical HES cases. Now, if you want me to continue at this point to talk about some alternative advanced testing, I'm happy to do that, but you decide.
Yes, please. Yes,
okay.
I think it's interesting to talk.
Okay, so besides that basic workup, so biochemistry to tell you about complement activation, and genetics, including antibodies, and genetics to identify mutations, The question often, especially in the ones in whom you don't find any of those factors, a mutation or an antibody, the question remains, do we have assays that allow us to generate evidence that these patients nevertheless have a complement-driven TMA? And for that, we do have a couple of assays that are a bit more complex and less a bit more difficult to assess or to kind of get access to. But I would want to at least introduce them to you and share with you that there's more sophisticated ways of analyzing a patient's basically clinical situation. So there's this so-called, many people refer to it as the Norris assay, Marina Norris, from Bergamo in Italy, published in 2014, I think, this blood paper, where she basically described to take endothelial cells, control cells, incubating them with the serum of patients. And if you look at the, and then detect by IF the deposition in green of C3 and C5b9 on the surface of these cells. And remember my introduction of the complement cascade. This is basically demonstrating that when you incubate those endothelial cells with patient serum, you get the terminal pathway activated on those endothelial cells. And you see, just looking at the histological pictures here, that compared to the controls here, the aHUS samples show more green, so more complement sitting on those assays. And they quantified this. Let's just skip that for time. And I'll show you how they use that now. So they, in that paper, presented two cases. This is a boy who, over many years, was diagnosed, I think, during the first year of life, in the end diagnosed with a factor H mutation, and was treated with plasma, failed, end-stage kidney disease, renal disease, had to be commenced on dialysis, eventually transplanted with eculizumab. And this patient had, despite eculizumab treatment, this is C5b9 in the bottom system, on endothelial cells, after transplant with eculizumab, still more than normal threshold, which is this black bar, or this black line. You see the C5b9 deposition exceeding that normal level. So even though he had eculizumab, he needed more eculizumab to be completely controlled. And that's what they did. They increased frequency and dose, and then measured again C5b9 deposition on endothelial cells and achieved that, which you can see here in the bottom right bars. And then similar to that, or in analogy to that, an adult patient also transplanted with eculizumab, pre-transplant, high C5b9 deposition on the cells, and then post-transplant completely suppressed. That was with standard dosing, and then they tried to maintain that dosing with less frequent dosing. So they went from every 2 weeks to every 3 weeks and achieved that. So they continued to treat the patient with less frequent eculizumab infusions. So that's how this assay is helpful to navigate complement management, anti-complement treatment management of those patients. There's another assay, which is, you specifically asked for that, this modified HEM test. So if you are confused, then stop me. Otherwise, I'm happy to explain. So what that basically allows you to do is similar to the previous one, where your readout was, I take cells, patient serum, and the final readout is just the end product of complement activation on the endothelial cell. So that's how that assay, the previous assay, was assessing the complement system. This assay does something else. So this assay uses as the final readout the lysis of red cells. So they measure basically in the test tube at the end hemoglobin, right? And the way they do this is that they create kind of an experimental protocol where they use either antibody-sensitized sheep red cells or rabbit red cells. The rabbit red cells spontaneously activate the alternative pathway. The antibody-sensitized sheep red cells allow for the classical pathway to be activated. So now you have a model in the left column for the classical pathway, on the right side for the alternative pathway. And then they, let's not go into the detail, they compose the buffer in which those cells are incubated to allow for the classical pathway or the alternative pathway to progress. Okay, so you have cells that are ready to respond to either the classical pathway or the alternative pathway. And they kind of hold that kind of experimental sequence by introducing basically the equivalent to eculizumab. They stop the cascade at the C5 activation level. So you let everything that happens on the activation, in the activation portion of the complement cascade happen, either via classical or via alternative pathway, and you let it basically completely achieve its maximum effect in step 1 of this assay by blocking basically the sequence at the C5 level. And then they wash everything off. They wash the C5 blocker off and add serum and whatever it's required to let the terminal pathway happen. And then the readout is in step 2, the lysis of those red cells. And if you do that in parallel, obviously it's not in one test tube, it's one assay or the other assay to test for the classical and the alternative pathway, it tells you in the end of the day which of the pathways was really active in the setting of this patient's serum. That's the trick here. So they create a scenario where you can differentially test the classical versus the alternative pathway, and your readout is hemoglobin released from lysed red cells. And similar to that, sorry for exceeding here a little bit of what you have asked me, but I find this quite interesting and important. There is an equivalent to this heme test in the literature. It's not too well known, but I think it's quite interesting. Not applicable to TMA, but to the sibling disease C3G. This is from a group from Germany where they basically generated established a protocol that allows to immunohistologically detect the presence and activity of the classical or the alternative pathway convertase. So again, this is the same principle. You can differentially stain tissue to either identify the convertase that drives the classical or the alternative pathway. And they demonstrate that this is applicable and relevant since, start with the bottom since it's more impressive. They take a lupus biopsy sample and they see a lot of classical pathway C3 convertase staining here, as opposed to C3G, where we know to expect alternative pathway activation. That's what we find here. So this difference here can now be detected on tissue, and I find this quite interesting, and not too many people know about that.
Okay, great. I mean, very interesting, this part for the diagnostic workup that is evolving as we talk. So back to our patient. So the diagnosis is most likely And what is going to be the benefit of eculizumab or C5 inhibitor in atypical aHUS? And does it inhibit the thrombotic microangiopathy while improving renal function? This is my first question. And the second question is, what is the expected time to observe control of hemolysis and renal recovery in patients with atypical aHUS following complement inhibition?
Thank you so much. Now we're done clinical diagnosis, we're done differential diagnosis, we're done basically our laboratory and extended, more sophisticated workup of the patient. We know this is a primary, or we assume this is a primary complement-driven TMA patient. Now, how do we treat this patient? Since the beginning of the 2010 years, we are in the really comfortable situation that we have a specific treatment that blocks this terminal pathway that we highlighted a couple of times now already, efficiently and safely. And the treatment is eculizumab, as you all know, and the longer half-life version of this drug is ravulizumab. That's what we have at the moment, and there's generics and alternatives coming, and we will talk about that in a little in a moment. This slide just summarizes again the sequence of complement-driven terminal pathway mediated endothelial injury and the sequence of atypical aHUS with the clot formation and everything that comes with it. And it shows where the treatment works. Eculizumab is a monoclonal mouse-based humanized antibody that binds specifically to C5, one antibody binding two C5 molecules, and with that preventing all these steps downstream C5 activation. And with that, everything that is happening here within the terminal pathway is not happening anymore. And with that, the endothelial cells are not attacked anymore. So that's the principle of the treatment. And this is basically from the original paper 2013 New England Journal that describes the results of the trials, the clinical trials that led to the approval of this drug. And I want to draw your attention, since your question was how quickly do we expect this to work, to the right bottom, since this is basically documents how quickly eculizumab treatment blocked in the patients in the trial the complement system. And this is demonstrated as a CH50 kind of the change in CH50 level, which is representative for global activity. So 100% is basically fully active, 0 would be 0 active. And you see that this, without, besides a couple of blips here and here, both trial arms, there were 2 subgroups of patients, acute patients and chronic patients, both within minutes to hours were completely complement blocked. So that's the first part of the answer. So the complement blockade is instantaneous. And it's ongoing as long as you abide by the recommended treatment protocol. And I showed to you that some patients may do well with even less. Some patients, a very small subgroup, needs more, but by and large, the recommended dosing works well. The top 2 levels show you the benefit in terms of improvement. I think this is platelet count. In here the acute and here the chronic patients, and the bottom left shows the improvement of GFR as a result of treatment. Treatment starts here. So this is basically the answer to the question: how quickly do you expect the drug to work instantaneously? How quickly do you expect improvement in the functional parameters, stop hemolysis, improve kidney function within days to weeks? And just to jump ahead of the game, how long for do you expect to see that effect, or do you expect this effect to might become obvious, or to apply if you want. Up to 6 months is what people agree upon. So you should see the most effect really within days to weeks. In patients in whom you see a little benefit and you don't want to give up to 6 months is reasonable to continue to try. After 6 months is kind of probably unlikely and not recommended anymore to continue with treatment if you haven't seen any benefit. What I have shown you in the previous slide was basically a patient without a transplant. This is the slide that summarizes the benefit in the French cohort of aHUS patients of using eculizumab in the transplant population. And you see here, early 2010s, that's when eculizumab became available. The number of patients who didn't need a transplant since their native kidneys were protected increases. The number of successful transplants increases since those patients don't, with eculizumab protection, do not experience any relapses anymore. And in gray, the patients who proceeded or progressed to end-stage renal disease and required renal replacement therapy and form of dialysis decreased. So this is basically, they call this basically a treatment that changed the epidemiology of the disease. That's a quote from that paper. Since we're talking about time in terms of the treatment, there is an important paper which you're intuitively aware of, but it's maybe good to have this reference on mind as well. It matters when you start treatment. So time matters. This is basically a paper that looks at the mean change in eGFR top left in patients who were treated within a week of diagnosis versus after a week of diagnosis. And you see the split of those two trends over time without a change. So both cohorts remained on treatment, but you see what happens in terms of outcome, in terms of improvement of kidney function. And the bottom right basically just illustrates the same message with a different currency. This is to demonstrate the portion of patients achieving the so-called eGFR response, which is an improvement of at least 15% of improvement of eGFR. And you see the early starters less than a week or less than 7 days within the first week being the black bars, and the ones who were later started in the gray bars. And again, there is no catch up over time, right? So it really matters, what you do in the beginning. It's time sensitive. Everything I've shown you so far is eculizumab based, but for a few years now, we do have ravulizumab, the longer half-life medication of a C5 blocking antibody. This is basically a slide that summarizes the message, comparing the two, eculizumab versus ravulizumab in dark blue, eculizumab in light blue, with respect to key outcomes, TMA response. So it's an aggregate platelet count, LDH normalization, 25% improvement of creatinine from baseline. You see that those bars are not statistically significant. So both treatments basically do the same job. And as you know, with the decreased frequency, you have a benefit to patient in terms of patient management and quality of life with the less frequent infusions. And in terms of safety, the profiles are similar between both. So there's really no downside and rather an upside to the use. And this is documented, especially in terms of the safety aspects, by a retrospective analysis published last year based on the patients in the global atypical aHUS registry. This reports on all patients who switched from eculizumab to ravulizumab between 2019 and 23, as you can see here, including all age groups based on the global registry. You see here, how these patients presented in terms of underlying conditions. It's a relatively small fraction. I said up to 60%. This is only about a fifth or quarter of patients who were diagnosed with mutations. Antibodies in just below 20%. None of those patients had any significant relapse or decline in kidney function, and that is reflected by no dialysis or transplant. No new dialysis or transplant, and reflected by the respective laboratory parameters and the absence of significant specific adverse events. So the message is this was documented to have been safe in that retrospective analysis in a large cohort of patients.
Great. I think it's important to note for no differences in terms of the benefit of aHUS versus aHUS. So let's say this patient diagnosed most likely, and then eculizumab started. So sometimes this will be challenging because the cytopenias will not be recovering within a week or two, and you will be concerned about could this be a factor H autoantibody mediated atypical aHUS or something else that is making this refractory? So when do you consider the additional plasmapheresis on this suspected atypical aHUS cases?
Yeah. So that's an important question. If you, now the pediatrician speaks again, if you go back to the very early, like the beginning of this presentation, where we spoke about the establishing of this TMA diagnosis and navigating between the key differential diagnosis, and I said STEG-aHUS is one. It's kind of, the clinical, the HBI of the patient is pretty telling. So let's say we're done that, then especially between adults, for adults, TTP remains one of the key diagnoses. And the threshold for hematologists where TTP is higher up on the differential list before you have the ADAMTS13 levels to initiate plex is much lower than for pediatricians. For pediatricians, we would not consider TTP. We would, at that point, done chigatoxin aHUS. Even before we have the ADAMTS13 level back, we would initiate eculizumab and would not plex the patient. You might do it differently. You might do it the other way around, but we can talk about that. And the concept would be that in any type of atypical aHUS, including the version with antibodies, eculizumab is the treatment that is expected to block activation of the terminal pathway, with that prevent pathology, prevent the phenotype. So if you are failing in a sufficiently treated patient, if you're failing to achieve resolution of TMA phenotype with eculizumab, you should seriously reconsider your diagnosis. Again, all components of this statement are important. You need to make sure that you don't have a highly proteinuria patient and you're just underdosing the patient, right? That's an important aspect. So sufficiently treated, and you fail with eculizumab to achieve resolution of the TMA phenotype, reconsider your diagnosis. It might be something else that is not complement driven. Now, and with that, the honest answer to your question, where is the role of PLEX? Actually, in a true patient with primary complement-driven TMA, it's almost absent, with one exception, and that's what I'm showing you here on this slide. If you have a patient in whom you identify antibodies in the red box top here, you basically deal with a situation where complement blockade, C5 block, German pathway block, will still, regardless of the underlying cause, genes, mutations, or antibodies, will still block your phenotype or reverse your phenotype. But now you have a patient in whom you can basically treat the autoimmune cause. You can undo this autoimmune cause, and you can, with that, work towards discontinuation of treatment relatively soon. And that is where the role of PLEX is. So in a patient who, and that's kind of tried, those algorithms are, this is one, and this is close to what the IPNA recommendations will also present. And I give you this one since it is from India. And I mentioned that earlier, that India has the biggest, the largest cohort of patients, and with that, the largest, the most experience with these patients. So this is really wetted in terms of patient management experience. So they say that if your patient is started on eculizumab, let's say it's a child, started on eculizumab, antibodies are found, you continue with eculizumab, and you consider PLEX, especially in the patient in whom the antibodies are high, so that you get rid of those antibodies. Now, the other way around, if you have a patient who happened to be started on PLEX, antibodies are found to be elevated, you can continue to PLEX this patient, only if this patient under PLEX is not well controlled. You would, or in patients in whom PLEX is not sufficient to control the disease, additional or switch to eculizumab, probably combination is what's recommended. But then the plus is now important. The goal, the overarching goal of the treatment approach here would be, under complement control, you want to get rid of these antibodies. And that's what you do with immunosuppression. So you add steroids and consider the addition of MMF or cyclophosphamide. If patients are refractory, you can intensify PLEX treatment and or combine PLEX and eculizumab. And so you combine the two treatments. That's the message, right? And you escalate with the ultimate tool of stopping the disease being eculizumab. That needs to be clear in people's mind. And then the final step is the mid and long-term trajectory. So the idea is, with these PLEX and autoimmune treatment measures, the idea is to get the antibodies down. At that point, when they reach normal levels, are not elevated anymore, at that point, you can consider to discontinue eculizumab, and you can withdraw eculizumab, and then you follow with immunosuppression for some maintenance for the duration of probably up to 2 years, and then you can probably safely discontinue even the immunosuppression, the maintenance therapy. It's obviously slightly different in patients in whom you were not good enough to control the disease, where you would withdraw treatment and you would prepare the patient by genetic workup and so on with supportive therapy to get to a transplant situation. So once again, concept is if there's antibodies, eculizumab still controls disease, but there's plex plus minus immunosuppression to get the antibodies down, followed by immunosuppression for maintenance. When the antibodies are down, you can discontinue eculizumab, and the maintenance immunosuppression can typically be discontinued after about 2 years.
This is very interesting because I don't really know if I may be mistaken. So if I don't know if India has C5 inhibitor therapies that is available.
Yeah, an excellent point. Thank you for bringing this up. I've spoken to the senior author, Arvind Bhaga, and obviously the concept of treating an autoimmune disease, which is also defended by countries, with access to eculizumab like France, but in India was driven by the absence of access to eculizumab. So they had to use anti-autoimmune treatment or antibody treatment. But I still think that the combination of the two treatments is the best strategy. I would not make it, put your money on one or the other. Since this is a treatable disease that really allows for complete discontinuation of treatment if you do it the right way. And you can do it safely since you always have eculizumab that controls the disease when you need that.
I think this also this also gives the point that the factor H autoantibody testing needs to be done at the time of the treatment decision.
Absolutely. That's why I had it on the slide a couple of times. Antibodies are part of this basic workup, and maybe they might, in my mind, they're even more important than the genes, since you can't treat the genes, but you can treat the antibodies.
Okay, great. I think we have a couple more minutes, so I want to just just move on because let's say this patient was on C5 and then gene panel came back unremarkable and factor H antibody is also unremarkable. So when we consider the discontinuation, and what's your approach after the discontinuation?
Yeah. So the quick answer here is discontinuation is practiced and will be recommended to be considered after 6 months of treatment. And that is true also for transplants. In various studies, it has been shown that the presence of mutations and a family history of atypical aHUS and also the extent of the extrarenal manifestations are negative predictors in terms of risk. That's this study, again, based on the international registry. And this is confirmed by a French study. I just summarized that slide for you. It's again, you see it here, it's the presence of mutations that really predicted the risk of recurrence. But nevertheless, all of these studies in the end recommend discontinuation after 6 months and then basically monitor the patients clinically, in particular clinically, not so much with blood work, that is needed as well, but it's more clinical observation, and it is urine testing for hematuria, which is one of those markers that helps to kind of identify disease activity or recurrence. There's a different opinion in the literature, and I want to share that with you, which is the Netherlands, that basically use a protocol where they discontinue treatment after 3 months. They kind of weigh this a little bit. Children different from adults, patients with a transplant a little different, and patients with a relapse a little different. But by and large, instead of 6 months, they do 3 months. And I just click to this slide here, where they say that was their Curious study. You see the name here. And this is published now, 22, where they say it's safe and cost-effective to discontinue eculizumab after 3 months. So this is the most aggressive recommendation in the literature. And they kind of highlight the positive outcomes and the cost reduction kind of benefit of that strategy. But they also say we need more data to really confirm that this is safe in the long term. But that's basically the two opinions in the literature.
Okay, I think I will move to this slide if it's okay with you. I mean, for practical purposes, I mean, I think my clinical practice has been if they have one of these detected gene mutation, then I will be less inclined to discontinue, and I would rather to go for a year and then decide how to proceed based on the C5b and 9 level. But again, I think we need more data because some of the people who relapse on the after discontinuation had some refractory renal failure based on the Fakuri's paper that was published, the prospectus trial.
So I appreciate what you're saying, and of course it will remain an individual decision. But I'm just sharing with you what kind of the widest consensus is in the literature. And it's not landing on the aggressive 3 months. It's most colleagues in the community would agree that 6 months is reasonable. I think the key is that if you monitor those patients, actively and educate the patients, to monitor themselves, most of these recurrent events are treatable. And the ones that you're referring to, I skipped that for time on the slide, of this Fakuri blood paper, where going into the experience of withdrawal with an underlying chronic component of their kidney disease. So it was pre-injured kidneys that kind of progressed to, it's a little bit of a hand-waving argument, I accept that. And I'm not defending, but I'm just saying that in my own experience we have, I think, relatively strong data to support the 6 months, maybe 6 to 12 months, but with individual exceptions. If you have aggressive mutations, a family history, you have lost a kidney in the past, that's a different story. In those patients, you may even have to consider lifelong treatment.
Great. Do you want to talk about evolving landscape for the
so that's then it's the second to the last slide, if I may. That's basically this here. Back to the complement cascade. You remember we have seen that, and the question is, what's in store moving forward? Remember, everything that is dysregulation of the terminal pathway would be aHUS related, and what we have there already available is eculizumab and ravulizumab as a C5 blocker. There is an siRNA treatment coming up, which is just in a different by a different strategy, silencing C5 transcription and translation. We have crovalimab, which is another C5 antibody. I think it's Bayer. And then there is Coversin and Numacapan, which are small peptides acting as C5 inhibitors. So there's a couple of, besides the generics that are coming from a couple of companies for generic C5 inhibitors. That's the drugs that are in trial. We have, just to be complete, also very promising data coming out of C3 and alternative pathway blocking medications, pegcetacoplan, a C3 blocker, iptacopan being a factor B blocker, and in trial factor D antagonists being quite promising in treatment of C3G. you know the literature of, or you're aware of the literature of C5a receptor antagonism for ANCA-associated vasculitis. And then there's this lectin pathway blocker that might play a role in IgA nephropathy, the narsoplimab.
Yeah, great. Thank you. I think we went over a lot of very, very important points in terms of diagnostic workup, how to treat, when to expect the recovery, and when to consider the discontinuation. And I think this last slide is another important slide that just to highlight what mistakes made by, I want to make more wide and say any hemato-oncologist or nephrologist providers when managing atypical aHUS.
Yeah. So I'm you pushed me to put this down on a slide. So this is said all with all respect and humbleness. But I think a very practical, simple point. Make sure that blood is collected and it's enough blood and stored the proper way, so that you have treatment naive samples before you touch the patient with any flex or blood product treatment, since you won't ever go back to that scenario. So that's one of the key problems that we experience almost on a daily basis with our patients. So please kind of take that as a take-home message. The next one is I alluded to that. Maybe I don't have to go there anymore. It's this kind of basically referring to the tree of establishing the differential diagnosis and being too, let's say, background driven, rather being a hematologist versus a nephrologist in terms of what you think what you first consider as your differential, your most likely differential diagnosis. So have an open mind, basically, is the message, and don't settle on something that you think it is based on your background as hematologist or nephrologist. And as a yin-yang to that, consult the nephrologist with hematology and the hematologist with nephrology. And then the very dear and important to me is this spectrum of TMA. Unfortunately, we don't have the time to talk about that anymore. I mentioned that twice. There is a potential timely limited role for complement targeting treatment in the spectrum of secondary TMAs. These are not complement-driven diseases, but they are complement pathology enhanced diseases at the time of being presenting acutely, and that is your window of opportunity. And the quicker you are to establish that, the more you can benefit the patients. Remember, time is important. The sooner you start, the more damage you can prevent in the long term. And that is basically then the flip side of that kind of same statement. Consider in those TMA spectrum cases, in a meaningful way, the potential role of complement targeting treatments, and do it early.